Well, welcome everybody. My name's Amer Shoaib. I'm an orthopaedic surgeon at Manchester Royal Infirmary in Manchester. And I'm here with my friend and colleague Raheel.
Hello,
Raheel is a consultant in Jeddah in the Kingdom of Saudi Arabia, and he's the head of training at that particular institution. So today we're going to be talking about damage control orthopaedics, which is something of a hot topic, especially in trauma. And we're going to kick off by going through a case. So Raheel's going to present a case to you, and we're going to have a little discussion about the management points. Okay, over to you, Raheel.
Thanks, Amer. Welcome, everyone. We've got a case we're going to kick off with just to get a flavor of where we are at with this topic. There's a bit of evolution in damage control orthopedics, and Amer is going to touch upon that in his talk. Through the course of this session, we're going to have polls being pushed to yourself. Feel free to answer them, get involved. They're all completely anonymized, so don't worry. And we'll be discussing the results as we go along. So here's our first case. We've got a 40-year-old who basically decides to jump off a two-story building in the evening, and he is intubated at scene as he has a lowered Glasgow coma score. And the paramedics notice that both his legs are deformed, and they're suspecting bilateral femoral fractures. He has a head-to-toe CT, and some of the images you can see below. As you can see, he seems to have a space-occupying intracranial bleed and bilateral femoral shaft fractures. The chest and abdomen are normal. So, Amer, what are your first thoughts with this case?
Well, it's obviously complex because he's got a serious head injury, and so obviously I'm worried about the fact that we don't want that head injury to get worse, and at the same time he's got bilateral femoral fractures, so I'm worried about the amount of blood that he might have lost from the femoral fractures, and they look like segmental, quite complex femoral fractures, so I'll be worried about his blood loss and whether he's hemodynamically stable or not. So yeah, it's a complex case.
So Amer is being polite. What he's actually thinking is, why did I swap my on call for tonight? Correct?
Yeah,
okay.
It's 8 o'clock. Yeah.
Yeah. So let's have a look. We'd like you to answer this question. There's a poll coming through to you. Your priority is A, B, C, D, E, C, A, B, C, D, E. Call the neurosurgeon and apply splints to both legs. So which one would you like to go for? Feel free to answer that poll, and we'll get Amer's thoughts. Amer, sorry, just to lowering the volume on your computer because there's an echo of my voice coming through. Okay, so Amer, can you just talk us through the concept of ABCDE versus CABCDE?
So in one of the previous talks, we've talked about blunt trauma and penetrating trauma, and essentially the CABCD approach is used when you are worried that the patient's going to bleed out. So if they've got an amputated limb or they've had a penetrating trauma and you're worried that, especially if it's isolated, you're not so much worried about airway and breathing, but you're more worried about the fact that they're going to bleed out, and that if you go through the rigmarole of formal ATLS, you might get to see and find out that they've lost a lot more blood while you've been assessing them. So the C is really to, if you can do something quickly to stop the bleeding, then you do that, and then you go back to the formal ABCDE approach of ATLS. So what we're talking about is essentially blunt injuries, but you could say, well, he's going to lose a lot of blood from his femoral fractures, and that's part of circulation. But because he's got head injury as well, I think I'm going to be starting with the airway. Now, calling a neurosurgeon, well, good luck with that. It's difficult to get a hold of the neurosurgeon, and secondly, they're not going to do anything immediately that's going to change the management. The last answer is applying splints to both legs. I think that's a sensible thing to do, but
What's your top priority?
You've got to prioritize. So I'd start with the airway. So it'd be A, B, C, D, E for me.
Okay, so let's look at what the audience has answered. 50% have gone with C, A, B, C, D. So what they're trying to tell us is they want to control the circulation first and then move on to the airway. As Amer has alluded to it just a moment ago, it's a good idea to do that if there is active bleeding going on and you can actually see bleeding from a penetrating wound. So I think we still stick to the basics of ATLS in this case, and the right answer is A, B, C, D, and then reassess.
Yeah. Yeah,
Okay.
but there is an argument for both. So, like we've said in several previous talks, it's controversial, and there might not be one right answer. But so long as you've got an approach and you stick to it, I think that's helpful.
Absolutely. Okay, let's move on. So this, lucky for you, Amer, unlucky for you that this patient's in your hospital during your on call, but lucky for you, we've got a neurosurgeon and she's on her way. Okay. So,
fantastic.
Yeah. So what are the factors that we need to, which are important to avoid for the optimal management of this head injury?
Right. So, sorry, carry on.
So we're going to push that to our audience in a moment. And if you can just talk us through those. Is it hypotension, hypercarbia, hypoxia, or hypocarbia? Hypoxia, hypotension, hypocarbia, or hypercarbia. So I get, I think we're going to flip a coin on this one. I get a feeling. Hypocarbia, hypercarbia, hypotension, hypoxia, or hypotension, hypoxia, hypercarbia, and hypocarbia. So just to quickly recap, hypocarbia, reduced amount of carbon dioxide in the blood, hypercarbia, increased amount. Yeah. So what are we looking at here? What's the thought process behind this?
Right. Well, what I'm thinking of is that when you've got a serious head injury, there'll be an area which is not salvageable, and there will be an area which is healthy, and in between the two, there's an area which is potentially salvageable, and the priorities that you're going to be thinking of in order to keep that bit of the brain alive, to stop it from dying, is to get it oxygen and to get to have a decent blood pressure. So it's actually pretty much the same question as the first question we had, which is, how do you keep a patient alive? Well, airway, breathing, circulation. So I think hypoxia would be my number one, and then I want to avoid hypotension because it's no good having oxygen in the blood but not being able to perfuse the brain. Now, I did do a neurosurgery job many years ago, and I know that if you have too much carbon dioxide in the blood, then the vessels dilate, and if you have too little, then they constrict. So I'd say that I want to try and avoid the constriction. So that's hypocarbia I try to avoid, and then hypercarbia. I think ideally you want to have the PCO2 in the normal range rather than having any one of them. But if I had to choose the lesser of two evils, I'd say hypercarbia is the lesser. So I'm going to go for answer number 2, which is hypoxia is the first thing I want to avoid. Then hypotension, then hypocarbia, and hypercarbia. Is that what you're thinking as well?
Fantastic. And importantly, the majority of the audience seems to agree with that. So it's a happy balance we're trying to hit, where there is enough perfusion in the brain and there is enough oxygenation occurring as well. We don't want to sort of cause constriction of those vessels, and at the same time, we don't want to cause too much dilation and cause edema in the brain. So yes, I think you're absolutely right there, Amer. Great. So let's see where we are now. So that patient came in at 8 o'clock in the evening. We're now in theater at 11 that night, okay? The patient has a heart rate of 100, a blood pressure of 120/85, so ticking along hemodynamically. The PO2 is 13 on 100% oxygen. Now, what's your choice of treatment going to be? We're going to push that poll across to our audience as well and give them a chance to answer. The options are bilateral nails for those femurs. We nail the left side and put an X-fix on the right. Bilateral X-fixes, or left side nailing and right side retrograde nail. So let's give the audience a moment. Now, So this is an interesting one. What we've got to think about is this is not your box standard polytrauma. It's a head injury. Correct, Amer?
Absolutely, yeah.
And how does that make us differ our management in a patient?
Well, we sort of answered that in the previous question, because what the things we're trying to avoid are hypoxia, and we also want to avoid hypotension. Now, I'm not, even though I like to think I'm a good orthopedic surgeon, but I know that my patient's going to bleed if I perform a nailing, and if I try and perform 2 nailings, then I'm going to make them bleed potentially a lot. And although in the literature it says that nailing femurs, especially bilateral femurs, is a good thing to do, less than 24 hours. This is not the same, because there's a head injury as well. And I'm mindful of the head injury changes how I would approach this. So I would say, well, I don't want to put in a nail and lose a lot of blood and also risk fat emboli. And the fat emboli could potentially cause problems in the lungs. And fat emboli also can go to the brain as well. So even in patients with no patent foramina ovale, so there's no connection between the left and the right heart, for some reason which we don't understand, they can still get fat emboli in their brain. So I'd be wanting to try and avoid a further insult to the brain, and I'd want to avoid hypotension. So in this situation with the head injury, I think I might actually say, no, I'm not going to put in a nail, and I'm going to go for the external fixators, just as a temporary fixation, so that I can protect the brain and protect the lung from ARDS and fat emboli syndrome.
I think most of the audience.
Do you think the timing is 2300?
Yeah.
Raheel, if you had to consider doing a bilateral femoral nail, would you do that at 2300?
So I think you've hit the nail on the head, no pun intended, that the patient who has a head injury is a very different kettle of fish compared to one who hasn't in a polytrauma. So we're going to look at, Amer is going to give us this talk in which he's going to explore the concept of damage control orthopedics, early total care, and early appropriate care. So there is a lot of literature, which O'Toole's paper, which suggests that early nailing within 24 hours is a good idea, but when a head injury, it's going to cause more insult. So I'm totally with you on this one. We sort of consider bilateral X fixes. The timing, it depends on where we are at. Yes, at 11 o'clock at night, it's probably not the best time to start nailing 2 femurs. But if this patient did not have a head injury, we want to get into that window within the first 24 hours where we can provide early total care, so that this patient doesn't have increased morbidity and possible mortality as well, which is associated. So yes, the timing is crucial. You don't want to be starting nailings at 11, but it depends on if the patient did not have a head injury. If the patient did not have a head injury, we'd go with nailings. If we had a team which was appropriate and fairly experienced trauma surgeons doing this at that time with the staff.
Right. The thing that worries me about being late at night is that, first of all, I might be tired, the theatre team might be tired, the anaesthetist might be tired, and we might be thinking, well, should we do the quickest operation possible? I mean, I'm just talking if there was no head injury, and with bilateral nailing, in the best of hands, it's still going to take 3 or 4 hours. And it's a time of day when the least number of people in the hospital to come and help out if there's a problem. And at night you might have the night staff who are not used to performing nailing. So I think the timing also makes me worry about, even if there was no head injury, maybe I'd be reluctant to put nails in the middle of the night, because there are other factors at play.
Appreciate that. I think the caveat is that we need to have a reasonably experienced staff in the theatre or the OR time. And if that's the case, then I think what's best for the patient, if he does not have a head injury, is yes, I take your point. In the real world, things are slightly different. Okay, great. So we've that was just to give us a bit of a flavor as to this topic. and where we are at. We've had some suggestions that we should be looking at more info before we decide as to the base excess and the lactate levels for this patient. All that's going to come in a few moments when Amer starts giving us the evidence-based for damage control. So over to Amer on this one.
Okay, so as always, there isn't a black and white in orthopedics like in most of medicine. There's lots of greys, and this is a really good example of how things are not as clear as you would hope they were going to be, and also what we think 1 year changes over the course of time, and 10 years later we think things are much we think very differently, and we might have an altered opinion on the same situation. So what I'm going to do in this talk is we're going to start off by looking at the origin of the term damage control, because I think that's very interesting and there's some really good parallels that we can learn from. And then look at the definition of damage control within orthopedics itself. And then what I thought we should do is basically go back 40, 50 years and look at how damage control and our different approaches to dealing with the polytraumatized patient have changed. And then after going through the changes in damage control approach, I thought perhaps we should talk about the concepts that are useful to us now and talk about how that might help us in our decision making in real life, in practice. And then at the very end, I think it's useful to talk about mass casualty situations, because that's another area where this damage control approach can be very useful. So let's start off with the origin of the term damage control. Well, this is actually a naval term, so it comes from the US Navy. The United States entered World War II in December 1941 when Pearl Harbor was bombed. And essentially, the US Navy had to come up with strategies to try and keep their fleet fighting and to avoid the loss of warships. And they basically narrowed it down to several criteria that were causing their ships to be lost. One of them was flooding. One of them was breakage of the ship, so breaking up. One of them was severe fires on board, and the last one was explosions within the magazine where the ammunition was being kept. And of course, because it's a fighting force, what they want to do is to return that ship to war fighting as soon as possible, and that means preventing the ship from sinking. And so they developed tactics really to allow them to stop the ship from sinking. So the first one is to maintain stability of the ship, to fight fires on board, try and prevent explosions, especially in the magazine, and also have particular means for repairing battle damage. And they actually had officers on board whose job it was just they were called damage control officers, and all they were supposed to do was to organize the recovery of the vessel to stop it from sinking, and essentially to live to fight another day. And in these pictures here, you can see some sailors using a box to try to close a rent in the hull, and on the right you can see someone trying to stop a leak. And there are lots of parallels with orthopedics. So if we think about orthopedics, when we talk about damage control, what we're trying to do is to preserve life in our polytraumatized patient. And just as with ships, what they want to do is to live to fight another day. We want our patient to live to fight another day. So we've got to use a series of tactics to try to preserve our patient's life. And that's by trying to prevent them from developing adult respiratory distress syndrome or multi-organ dysfunction syndrome, or basically by controlling their physiology. We want to control hemorrhage. We want to try and avoid clotting disorders, and we want to stabilize their long bones, because long bones will bleed, they'll cause pain, and there's a risk of fat embolism as well. So what we're trying to do with damage control orthopedics is do the minimum amount to try and preserve our patient's life. And we're going to talk about the second inflammatory hit a little bit later, but we're trying to get our patient to live to fight another day, just like with the ships. So let's go to a poll, and as always, there's these polls are anonymous. We don't know what answers individuals have given, and it's just useful for you to know how, what you think compares with what other people are thinking, and also it gives us an idea of what you're thinking, and then we can try and focus on those areas. So far, everyone has said that trauma is the biggest cause of death in the under 40s. Nobody's gone for cancer or infectious disease or heart disease. So we'll give you a little bit more time if there's still a few people who haven't voted. So Raheel, which one of those answers are you going to choose? Which is the biggest threat to life in the under 40s? So are you muted at the moment? I can't hear you.
I think I'm going with the audience there. So that's 100% for trauma.
Absolutely.
Okay.
So yeah, trauma is the biggest killer for the under 40s, and even in under 80s, it's the third biggest killer. So what I thought we should do is talk about the evolution of damage control. And I thought that one way that we could try and remember this is by looking at hairstyles over the last 50 years as well.
You had quite a name there, Mr. Shoaib, back in the 70s.
I had a bit more of a beard as well, yeah. So this is a typical haircut from the 1970s. And as we said, trauma is the biggest cause of mortality in the under 40s. But in the 1970s, there wasn't any clarity in how we should be approaching these polytraumatized patients. It was noticed that patients who underwent early fixation seemed to have problems. And those problems seem to be things like fat embolism. So fat embolism basically means that in the long bones, if they were manipulated or if they were penetrated by intramedullary nails, people suffered showers of fat emboli that went up through the venous circulation, and it could cause a fat embolus syndrome and compromise the lungs. And this might be mechanical, so it might be that there are physically bits of fat going and blocking vessels in the lungs and causing mechanical damage, or it may be because of a biochemical reason, that the free fatty acids themselves are causing damage within the lungs. But either way, it caused a severe inflammatory reaction within the lungs, and this led to multi-organ failure. So it was felt in the 1970s that there were some patients who were polytraumatized who were actually too sick to have surgery, and if we operated on them, we were going to get a bad result. So patients tended to be kept on bed rest, and then after a significant period of nearly a week, then they might have their definitive surgery, because it was thought that it was safer than having the early surgery. So let's move on from the 1970s. It was noticed that in some patients, if early stabilization within 24 hours, and there were lots of papers that demonstrated this, it actually reduced the fat embolism rather than making it worse. So there was a change in the way that people thought, and it seemed that patients who had their surgery within 24 hours seemed to do better than those who had their surgery after 48 hours or 72 hours. So they developed a new approach, which was called early total care. And what that involved was the patient would go to the operating theatre, and if they had 3 or 4 different fractures, they would stay in the operating theatre until all of those had been addressed, so all the long bones had been fixed. And whereas in the sort of 1970s, we thought that patients were too sick to have surgery because of the risk of fat emboli, the thought process changed, and now we're considering that patients were too sick not to have surgery, so they were going to benefit from having this surgery. And one of the knock-on effects was that it allowed patients to rehab better, and it was certainly true that there was some improvement. So Bone et al. In 1989 showed that there were less pulmonary complications after patients had been treated for bilateral femoral fractures, and their time spent on intensive care and in hospital seemed to decrease. So this seemed to really justify the approach of early total care from the 1970s to the 1980s. So this is the typical haircut from the 1980s, the mullet. Did you have one of those, Raheel?
I wasn't born in the 80s, Amer.
Oh, that hurts. That hurts. Right. So, early total care in the 1980s. It wasn't just the early total care approach. There were other changes. So, ATLS was introduced, certainly in the UK, in the late 1980s. The fixation technique, so nailing became a lot more common, and the instrumentation was a lot more reliable. So there were, operations didn't take as long, and also we were better at ventilating patients and supporting them from a cardiorespiratory point of view. So there were other things as well which might have benefited patients as well as the early total care approach. But even so, there were some patients who didn't seem to benefit from this early total care. And these patients were the ones who were unstable hemodynamically for some reason, who had a high injury severity score, patients who had chest injuries, and patients who were hypovolemic, so still shocked. So there was a bit of head scratching, and it was felt that there was something more to it than early total care. And the reason that it's thought that there was this problem was because of the inflammatory cascades. So the body has some very complex inflammatory cascades of reaction and then counter reaction with the increase and decrease in inflammatory mediators. And essentially, when you have multiple injuries, your body produces an inflammatory response to trauma. So you have these cytokines floating around. Now, if you have a certain level of cytokines floating around, that's obviously damaging to your body because it's been caused by injury. If you then go ahead and you operate on people and you perform extensive surgery and you cause lots of fat emboli, then there's a risk that you've got a patient who's already got very high levels of cytokines, and you're then going to give them another stimulus that's going to raise their cytokine level even higher, and we call that the second hit. And with COVID, we're all a bit more familiar with the term cytokine storm. So certain cytokines just seem to get elevated, and this was associated with the systemic inflammatory reaction syndrome, multi-organ dysfunction syndrome, adult respiratory distress syndrome, whatever you want to call it, but it was also associated with patient death. And so there was another group of patients who were treated non-operatively or without IM nailing, and instead of having the second hits, they had another cascade of compensatory anti-inflammatory cytokines was released. And again, it's the balance between what might be termed good cytokines and bad cytokines. But if you had a balance which was physiological, then it would actually lead to resolution. But if you had too much of a compensatory anti-inflammatory response, that actually left you open to you became immunosuppressed, and it made you more susceptible to infection. So you can have poor outcomes that way as well. But this is the origin of the term second hit, with the cytokines going up. And so it was noticed in patients who had been treated with early total care that not everybody did well. So Eke et al. Sort of noticed that some patients were unstable. They had early total care as it was advocated in the 80s, but they still had a lot of pulmonary problems. And Giannudis suggested that one of the reasons that this may be the case is because of the immunological response that we've talked about, the cytokines. And if we understand the cytokines more, perhaps we can understand how we can modulate this immune response so that we don't cause as much harm to our patients, so we can avoid fat embolism. And that would help if we can control the base excess and the lactate. That would certainly help. And also, interestingly, the timing of surgery. So that was honed down a little bit more in detail, so that we could see when it was that people's cascades of inflammatory mediators were causing a problem. So from that two-hit phenomenon, we developed the damage control orthopedics approach in the 90s and the noughties. And there's the haircut from the 90s. Did you have a haircut like that in the 90s, Raheel?
Probably did, Amer, probably did.
Okay, so what we're trying to do is to get use the smallest intervention to get the maximum effect. So it's not just one thing, it's a whole barrage of treatments. So we want to control hemorrhage and we want to resuscitate the patient properly. We want to think about the timing of the stabilization of the bone. So Pape basically said, if we look at the timings, less than 24 hours is good. Between days 2 and 4, there's a problem with the second hit, and the patient's very susceptible to having excessive levels of cytokines. And then it's safer after day 5 to perform the definitive surgery. So for the stabilization, we're going to use external fixation rather than the intramedullary nails, so that we can protect the patient from the cytokine storm, and also think about other risk factors for the systemic inflammatory reaction syndrome. And Pape came up with a series of categories for how we could sort of define patients, and he worried about coagulopathy, hypothermia, and acidosis, which we now would term the terrible triad of resuscitation. So these are the things that we're worried about, because it forms a cyclical process which results in worsening of the coagulopathy, of the myocardial function, with low temperature, poor coagulation, and metabolic acidosis. We're also worried about hypovolemia and hemodynamic instability. You'd be concerned about long surgical times, because all of this could lead to the cytokine storm that we're trying to avoid. So we've got another poll now for everyone to answer. So there's a 42-year-old man. He's been stabbed multiple times in the legs. The paramedics say that there's been a lot of blood at the scene. And when he comes in, he's tachycardic and he's hypotensive. And if you're going to stop his bleeding, because it's really important that we turn off the tap, but we need to fluid resuscitate him because he's lost a lot of volume. So what are we going to use to resuscitate him? So we could use warmed Hartmann's solution that will boost his volume. We can get that in very quickly. Or we could use colloid, and the argument that people use for using colloid is that it's the Hartmann's will redistribute very quickly into the whole body, and the colloid will stay in the intravascular compartment, so it will maintain his blood pressure. And the last answer is that we would use blood platelets and FFP in the ratio 1 to 1 to 1 in order to resuscitate the patient. So what are your thoughts about this, Raheel?
So this is a young person, and he's not on the borderline. He's actually in shock, Amer, if you look at the ATLS classification, because he's tachycardic and he's hypotensive, because as a young person, you'd expect them to compensate and keep the dynamics ticking along. But he's he's pretty much at the edge. So I would go with blood in this case, because you want to get FFPs, platelets, and packed red blood cells in as quickly as possible, because he's one to watch. He's going to crash on us any moment.
I agree, absolutely. So it just makes sense, doesn't it? If you've lost blood, you need to replace it with blood. And the problem with giving just packed red blood cells is that that's not going to help with his clotting. So he needs to have the platelets and FFP as well, so that he can form blood clots. And you're going to maintain his intravascular volume. And I'm pleased to see that the vast majority of our audience have agreed that the way to resuscitate someone in this situation is with blood, platelets, and FFP. So we're moving on to 2020. So this is our current haircut. The hipster type appearance. So we're now looking at resuscitation in 2020. What are we going to do? Well, we've talked about this before. If you've got penetrating trauma, if you've got an amputated limb and you're worried about someone bleeding out, and you can do something quick like put on a tourniquet or use some Celox or direct pressure, then you can do that and then go on to airway, breathing, circulation. But for blunt trauma, generally, we're going to just go with airway, breathing, circulation. We want to stop the bleeding with whatever tactics are possible. And one way of doing that is by stabilizing the long bones. And we want to replace blood with blood. So this is what we've just talked about in the last poll: FFP, packed red blood cells, and platelets. And tranexamic acid is pretty much routine now for these trauma patients. So the CRASH 2 trial basically seemed to conclude that it was in general a very good thing for these trauma patients to stop them from breaking up any clots that have formed that might be plugging their bleeding points. And most hospitals have now got a massive transfusion protocol. So, instead of having to think about how much blood you need, they all come in packs now. So it makes it a little bit easier for you to manage, and everyone is singing from the same hymn sheet. So here's another poll. So we'd like everyone to answer this question. This is another case from my own experience. 25-year-old policeman was riding a motorbike, and she hit a van in front of her. Now, as you know, a motorbike will have a big petrol tank in between the rider's legs, and so you slide forward and you tend to cause injuries to your pelvis. And she's brought in with pain in the pelvic area. She's tachycardic and she's a little bit hypotensive. So the question is, how much blood can you lose from your pelvic cavity? So we've got 500 mils, 1,000 mils, 1,500 mils, or 2,000 mils, so 2 litres.
The majority are going with 2 litres plus.
Yeah, so I think the vast majority of the audience have got this. They're all right. You can lose much more than 2 litres in the pelvis. And the reason is that if you consider the pelvis to be a sphere, the formula for the volume of a sphere is 4/3 pi r cubed. Am I right, Raheel? 4/3 pi r cubed. So if you double the volume, you get, if you double the radius, you get 8 times the volume. So if you have an open butt pelvis, as suggested by this question, then you'd actually increase the volume of the pelvis quite a lot, and you can lose a lot of blood. And I'd agree, you know, it's 2 litres or more. So this is where, as orthopaedic surgeons, we can sort of get involved in the C for circulation and hemorrhage control, because you've got to turn the tap off, you've got to stop them from bleeding, and you also want to resuscitate them. The pelvis can lose 2 to 4 litres, and the femur can lose 1.5 litres. So if you've got bilateral femoral fractures, you could easily lose 3 litres. So it's very, if you've got multiple long bone fractures, you could easily lose your entire blood volume, circulating volume in your long bones. And this was actually something that was really important in World War One. So the Thomas splint was introduced in World War One, and that actually resulted in sort of the rate of death from open femoral fractures being from 80%, and it reduced it down to 15%. And you know, the other areas that you might be bleeding, the pelvis, well, you can use a pelvic binder to decrease the volume of the pelvis by closing the book. And other things that you can use are things like a C-clamp or a pelvic fixator. And we talk about the concept of a primary clot. So when you bleed into your pelvis, it might clot, but if you elevate the blood pressure a bit too much, that might actually blow that primary clot. And if you don't have any more blood clotting factors because you've used them all in that primary clot, then you haven't got the ability to clot again. So that's why it's important to have the FFP and the platelets as well. If you've got retroperitoneal bleeding, as orthopedic surgeons or general surgeons, you could pack the pelvis by performing a lower abdominal laparotomy, going behind the bladder and just packing lots of swabs behind the bladder to sort of tamponade it. And the long bones, you know, we can use external fixation or the Thomas splint to basically splint them out, and that will help with bleeding instead of nailing, which could actually make them bleed more. So it was noticed that by applying this damage control dogma to everybody, actually it didn't make a difference to everyone. And there were some patients who didn't need to have damage control because they weren't actually ill enough, so they were actually stable. They could go ahead and have their nailing straight away because their physiology could take it. And the other thing that's a little bit concerning is that all those inflammatory mediators that we thought we were going to control, no one's actually demonstrated that those inflammatory mediators are going down or that we're stopping them from going up. So it's still a little bit confusing, and maybe, like with lots of things, we don't actually understand all these cascades as well as we think we do. And there's still a lot of work, and in 10 years' time, we might actually believe something different again. But what we do know is that you know, early appropriate care, choosing whether the patient has early total care or whether they have damage control, depends on the individual patient and their physiology. And we know that things like head injuries or thoracic injuries or hypovolemia make a difference. But what would be useful for us as orthopedic surgeons is to be able to define which patients need each particular approach and what we could use clinically to try and make that decision. And fortunately, you know, clever people have done that work for us. So Pape and Giannoulis have sort of led the way in talking about damage control and about the limitations of that, as well as defining who would benefit from it. So if we've got a patient who's stable, who doesn't have life-threatening injuries, well, you can, first of all, you're going to do a pan CT. You want to CT them from head to toe so you can identify all their injuries. And if they don't have life-threatening injuries, then you can use early total care. If you've got a patient who's in extremis, so they come in, they're shocked, they don't respond to a fluid challenge, they're decompensating, then that's the other end of the scale. You don't want to do early total care for them because that's going to lead to death. In fact, in those patients who are non-responders, you don't even want to do a CT you want to get them to theatre, and you're going to use surgery to resuscitate those patients. So this is what we would call a code red patient in my hospital. And then you've got the other groups, an unstable group of patients who respond transiently to a fluid challenge, to the blood and the resuscitation. These patients need to have a pan CT so you can identify where their injuries are, and they need damage control because there's still other work to do to try and stabilize them, and they're the ones who are more at risk of developing ARDS. And then you have the borderline patients who are responders to resuscitation, but they could go either way. So they might improve or they might deteriorate. And these patients need to have a pan CT from head to toe. And then we need to have some other means of being able to determine whether they get early total care, if their physiology is fine, or whether they get damage control if we're concerned that they might deteriorate from early total care. So fortunately, PAPE has defined these characteristics really clearly for us. The things that I'd like to bring out from this slide are the ones in red. So if you've got a patient who's got a chest injury, then so with an abbreviated injury score of 2 or more, and that means they've got multiple rib fractures which are displaced, or they've got flail chest. These patients are likely to do worse if you try early total care. So they may be the patients who need to have damage control. And similarly, if you've got abdominal trauma with a high AES, these patients you need to manage with damage control to try to limit the amount of inflammatory cytokines floating around in their body, which might make them deteriorate. O'Toole has also given us of other ways that we can look at patients and define what kind of treatment they have. So if their lactate is less than 2 milligrams per deciliter, then O'Toole says, well, actually they're fine, they're relatively stable, and you can give them early total care. If they have a lactate which is more than 2.5, then you need to continue to resuscitate them because you haven't finished resuscitating them, and you need to use damage control, so using external fixation rather than intramedullary nailing. And if they're somewhere in between, that's the grey area. And what we need to do is watch the trend in the lactate. So we carry on resuscitating the patient to try to drive the lactate down. And if they're getting better, then they might be a candidate for early total care. But if they're deteriorating, then we need to use damage control so that the patient can live to fight another day. Another aspect of the patient's care that we need to think about is their coagulation and the clotting cascade. And there are new things that we can use to help us decide how we need to resuscitate the patient. So there's TEG is one means of doing it, and there's ROTEM, which is a similar kind of clinical bedside test, and it gives you a result within about 30 minutes. And essentially what it does, it looks at blood clotting and it agitates the blood clots, and it measures the viscosity, and that viscosity is going to change over time. And the things that we want to know is how fast does the clot form, which is our R value. And if the TEG says that the R value is prolonged, that means we're taking too long to clot, then we need to give the patient fresh frozen plasma. Another question we might ask is how strong is the clot? So we might be forming a clot, but is that clot going to be strong enough? Now, a clot is made up of platelets and fibrin, which sort of glues all the platelets together. So if there's a problem with either of those components, then we might have clots forming, but they're just not very durable or strong, and they're not going to be able to plug holes and stop bleeding. So if we look at another parameter called maximum amplitude, which is MA on the TEG, then it might indicate that there's a problem with platelets or with the clotting factors. So it might of a fibrinogen. So we might need to give cryoprecipitate if the fibrinogen is low, or we might need to give platelets if the fibrinogen is normal, and we're inferring that the platelets must be low. And then the last thing we want to know is how long is the clot going to be durable, because there are cascades involved in the coagulation as well. So you've got the plasminogen to plasmin cascade. So that's going to cause our blood clot to be degraded. So we can look at things like the LY30, which will tell if that's too high, then that means that there's too much lysis of the blood clot, it's too quick, and that's actually degrading our blood clot and stopping it from maintaining sort of coagulation. So for that, we need to give tranexamic acid. Now, if you've got a patient who's on the novel anticoagulants like dabigatran, there's a specific reversal agent for that. But the other novel anticoagulants, the factor 10A inhibitors, there's nothing for that. So that produces a particular problem with our patients who are just going to bleed a lot. I think, you know, what's clear is that actually we need to think a lot more than just orthopedics. You know, orthopedics is not just about fixing the bones anymore. We actually need to think about a little bit more. This last slide, it's got a lot of relevance for Raheel and me, because we're involved in dealing with patients from the Manchester bombing. And the mass casualty situation might need you to use the damage control kind of approach. And what we're trying to do is to operate on as many people as possible, stabilize them. And we want to get the biggest benefit for the biggest number. So we might start off by triaging them to prioritize them. But rather than using intramedullary nails, which take too long and you know, might make some patients worse, we're going to treat everybody with external fixation, because it allows us to rapidly stabilize them and then get them out of theatre and move on to the next patient, so we can treat as many patients as possible.
Amer,
And
sorry to interrupt. We seem to have lost your video. We can hear you fine.
Right, sorry. And if we can treat all the patients rapidly, then we can stabilize them and come back to them later, and we can perform their definitive fixation. So whereas with damage control, we're normally looking at their physiology and their lactate and their coagulation, we're actually going to ignore all of that, and we're just going to stabilize them to get as much as possible, get as many patients through theatre as possible in the shortest possible time. So in summary, we've gone through the strategies that have been used over the last 40 years for treating these polytraumatized patients. We've gone from the 1970s, where we weren't really sure, the 1980s, where we went to early total care, in the 90s and the noughties, when we used damage control orthopedics, and now up to date with what we call early appropriate care, depending on the patient's physiology. And we've got means of deciding how we're going to treat patients based on their physiology. But it's still very clear that we don't understand everything about trauma responses and about the physiology and the pathophysiology. And I think we just need to reiterate what we're doing in orthopedics is we're trying to save life and trying to save limb. We're trying to get the patient to live to fight another day with this CABCD approach. So that's the end of my talk, but I'm just going to use this opportunity to just mention a charity that we run called OrthoCycle. And what we do in OrthoCycle is we take single-use devices from the UK, things like old rings and old instruments, and even old power tools like these pneumatic tools, and we take them to less developed countries so that they can be used there. We also organise courses. This is a course that Raheel and I have run in Manchester, external fixation courses and foot and ankle surgery courses. And the other thing we do is we treat people who don't have access to orthopaedics for free. So our current sort of aim is to treat Syrian refugees and people from Tanzania, and we treat them for free. So that's the end of my talk, but we're going to go through a few more cases with Raheel now.
Thank you, Amer, for a really informative talk, encompassing the entire spectrum of damage control orthopedics. Just so that we can summarize for our participants today, when we're looking at the treatment algorithm for these patients who've come with polytrauma, I'm just going to go through this with you, and you can sort of refine as we speak. We want to assess if this patient is stable, and then he gets a early total care, which is fixing every fracture in one sitting and get them up and get them going. We want to assess if they're borderline or unstable. And based on that, if they're borderline, we consider early appropriate care, correct? And if they're unstable, we just go for damage control orthopedics. And how we differentiate the borderlines from the stables is whether you're able to resuscitate the patient appropriately and they respond to your resuscitation within 12 hours. If they have a closed head injury, they straight away go into the unstable category, correct? Or a chest injury. And early appropriate care, for those of our colleagues who joined us a little late, is when you decide to fix the femur definitively and treat all the other bone fractures with either splints or external fixator. Is that a reasonable synopsis?
That's a really good, concise summary. Yeah, thanks, Raheel.
Great. So what we're going to do is going to have a quick look at a couple of cases before we wrap up to see what we've learned and whether we can implement some of the things we've discussed. So here is our case number 2. This is a 58-year-old who has been run over by a bus, and she has severe bilateral lower limb injuries. Tourniquets have been applied, and she has a hemopneumothorax. She has been intubated on scene, and she's been brought into the emergency room. What are our priorities? So we're going to push this poll to you. We're going to assess the C-spine first. We're going to insert a chest drain, resuscitate with fluids, or wound dressings. So this is someone who's had a chest injury, Amer. So by default, this lady falls into the possibly borderline or unstable patient, correct?
Absolutely,
We
yes.
don't want to go in there and start nailing these femurs and add insult to the traumatized lungs.
Absolutely, yes. So there's a hemopneumothorax. Yeah. So immediately, we know that the chest injury is going compromising her lungs, and if we nail her, then it's going to result in a second hit, and we're going to make her chest injury worse. Okay. And if we see there are a lot of people who've decided that they're going to look at the cervical spine. Other people have said that they're going to insert a chest drain, and others still have said that they'd go for fluid resuscitation. Mm-hmm. So it's quite a widespread, really.
It is, isn't it? It's interesting. What are your thoughts?
Well,
what would you go for?
Yeah, she's been run over by a bus. We're going to go with airway, breathing, circulation, and yes, we're going to think about airway with cervical spine control. But I think if she's been hit by a bus, if there's a cervical spine injury, it's probably going to be there, whatever happens. And I'm not going to be really assessing the cervical spine. I'm just going to immobilize it and ignore it because that's not an immediate priority. And then I'm going to move on to B for breathing. And I can see on that CT scan that the patient's supine and there's blood collecting at the back of the thorax, and there's a really significant pneumothorax there as well. So I think decompressing that is probably going to be my priority. So I'd if there was a sign of a tension pneumothorax, then I would decompress that with a needle.
Mm-hmm.
and then I'd move on to putting in an intercostal chest drain.
I agree with what you're saying, absolutely. I think, understandably, some of the audience has gone with the ATLS protocol of C-spine first, but she's been tubed. So although you don't assume in trauma, as you say, the priority is the chest because she's got a tube. She's not, her GCS is down to 3 now, so she's not going to be moving her neck anytime soon. So let's get that chest decompressed and then move on to going through the algorithm. Okay. So moving along, so a chest drain's been inserted and we've got 200 mils of blood which we've drained. It's now bubbling around nicely and she has been resuscitated with blood. Her pulse is 120, her blood pressure is 110 by 60, but she's acidotic with a pH of 7.24. Her lactate is raised at 4. Now her TEG and MA, as you rightly discussed earlier, these new clotting tools that we use are low. She's hypothermic. What does she need now? So let's have a poll with our audience. She needs to go to the ITU. We consider damage control orthopedics, correct her coagulopathy, continue resuscitating her with fluids, possibly blood, a warming blanket and temperature control, or all of the above. So what's the concern with this patient, Amer? There's alarm bells ringing here.
Oh, alarm bells everywhere.
Happy will be alarmed, won't he?
So the approach seems to be good. She's been resuscitated with blood, and she's made some kind of response. So although she's still tachycardic, she's got a blood pressure of which is quite reasonable, really. But the thing that concerns me is that she's got an acidosis, presumably a metabolic acidosis. She's got a coagulopathy because that's what the TEG is there to show us, that there's a problem with her coagulation, and she's also hypothermic, and that is the terrible triad. So each one of those is bad enough, but all three together is worse than the sum of them. And she's got a lactate of 4, so there's still some resuscitation that needs to be done as well. So this is a very sick patient. So ITU, she's very sick. Of course, she needs to go to ITU at some point. Damage control, well, we know that she's got quite severe injuries to her lower limbs, and she'd probably be bleeding from those. And those limbs are probably responsible for a lot of inflammatory cytokines. And she's got a coagulopathy. Continued resuscitation, we've said, she needs, because she's still not fully resuscitated. She's got high lactate, and she's still tachycardic, and she's cold. So I would actually agree with most of the audience, which is who have all plumped for all of the above, because all of those things are important for the management of this patient.
And a lot of the time they're happening in parallel.
Yeah.
Yeah. So agree with that. So all of the above is the right answer to that one. So unfortunately for this poor soul, things aren't getting any better. We've taken her to theater now, and her right leg is severely injured. There is no pulse in the foot. What's your procedure of choice now? We're going to push that poll to the audience, and let's have a think through this. We apply an X-fix and give her temporary stability. We call a vascular surgeon to revascularize the limb, perform an above-knee amputation, or replace the tourniquet because it will stem the bleeding. So this is a tricky one. She's quite unstable, and we've just discovered now that there is no pulse in that foot. What do you think we should do? So it's interesting, 60, close to 70%. Oh, it's ticking along now. We've got about 55% of our audience saying they would call the vascular surgeon. A third of the audience are saying they will do an above-knee amputation. So that's where the split is. Amer, your thoughts?
I'm looking at that picture, and what I see are very, very badly traumatized limbs. And the right leg is the one where there's no pulse. And I can see that there's a distal femoral fracture, there's a proximal tibial fracture, there's a shaft fracture. I think that, you know, the soft tissues as well also look very severely traumatized. You know, this is a mangled extremity, and this is a patient who's very sick. You know, they've got a lactate of 4, they are acidotic, they've got a coagulopathy. So what we don't want is for them to spend a long time in theatre, but as well as that, you know, what we don't want is to potentiate or make worse any of the current problems. So a lot of the audience have gone for calling a vascular surgeon to revascularize, but for a vascular surgeon to revascularize, you know, we've talked in the open fracture discussion that we need to shunt first, then we need to put an X-fix on, then we get a definitive vascular repair. But that's going to take a long time. That patient's going to be in theatre for more than 6 hours, and that leg is so mangled. I don't think that there's going to be anything to salvage. So I personally wouldn't say that the vascular surgeon is going to be able to revascularize that limb, because if they did try to do that and they spent 4 or 5 hours in theatre, this patient's going to just deteriorate and die. So I think in this particular situation, with that degree of trauma and with the physiological parameters that we've discussed, it's not worth revascularizing this limb. Now,
I'm going to go with an above knee amputation.
I think that would be my choice, and the reason is that putting an external fixator on, I've already said this limb is trashed, and I don't think it can be salvaged. So I don't think putting an external
that's quite an important decision you're taking there.
Absolutely,
and the practical implications of that for for anyone are significant. It's beyond life altering. So let's just tease that concept out a little more. In real life terms, you've said this is a mangled extremity, so we need to be clear in our mind, and the audience needs to be clear in their mind what a mangled extremity actually means. It's not just looks like spaghetti. So the definition of a mangled extremity is we've got bone, soft tissue, nerve, and vessels. If 3 of those are beyond repair, they're trashed, that's the definition of a mangled extremity. So Amer is going to look at that limb. He's going to assess, are the bones okay? Are they worth salvaging? Is the soft tissue worth salvaging, or is it salvageable? If there's significant loss of soft tissue, is the nerve or the blood vessels, are they salvageable? If 3 of those aren't, then it's mangled extremity. So that's one step you have cleared. This is a mangled extremity, you say. Fair play. Then moving on to taking that big decision of performing an amputation, would you consider getting a second opinion in
absolutely
OR, in theatre?
Yeah.
And that's best practice, isn't it?
Yes.
So let's say it's 2 o'clock in the morning. How would you go about doing that, Amer?
So, well, if the vascular surgeon was there, I'd be saying to the vascular surgeon, what do you think the prognosis is for this limb? Do you agree that in this particular situation, it's better for the patient to lose the leg? And also the anaesthetist would be there, and perhaps other trauma surgeons would also be there. And you're right, we need to get a consensus, because if we're making a decision of this gravity, we really need to be sure what we're doing, and it's not a one-person decision.
And we've all been there. Middle of the night, we've sometimes had to pick up the phone and speak to a colleague who's asleep in bed, saying this is the situation, this is what we're planning, and pretty much get consensus. And it doesn't take long to do that, even in an unstable patient. Okay, so I think we're in agreement, and above knee amputation in this instance, in a highly unstable patient with the triad is best to essentially save her life. And finally, with she's in ITU, so yes, she's had an amputation, as you can see, and that's day 3 in the ITU now. Now you're on your round, and the ITU consultant tells you, you know what, we've got to get this other femur fixed because she's been here for 3 days. What would you choose to do? Let's get the audience involved here. You would choose to nail her if her lactate is below 2.5, or if her PO2 is more than 5, or consider doing it after day 5 or after day 14. So let's see what give the audience a moment to take their pick. So you mentioned about this borderline patient and stable patient and the concept of second hit. Now, I know there's enough evidence out there which seems to suggest that if you wait for a certain period of time, your inflammatory response sort of dies down and that second hit won't be as massive as if you operated earlier. So what would, bearing that in mind, Amer, what would you go for? Would you consider the lactate? It's important, yes.
Lactate is something that we will definitely monitor, but Pape defined that between days 2 and 4, that's actually a dangerous time to perform definitive surgery on a patient, especially one who's been unstable and has got altered physiology. So I think the first two, obviously, we would be interested in a patient having a low lactate and being well oxygenated, but we want to do it after day 5. Now, after day 14, although her physiology may have improved, one of the problems of leaving an X-fix on for day 14 is that you're worried about colonization. And I know that Giannudis has written a paper which says that after 14 days, the risk of infection from converting an X-fix to an intramedullary nail really rises. So I would perhaps not wait as long as day 14, but I would definitely wait until after day 5 and hope that her physiology is sort of returned to normal with appropriate supportive treatment.
So you're going with option saying after day 5?
Yes.
Okay, great. Agree. And just to reiterate, any practice should be dictated by evidence. And there's a paper by Bonnetal, which Amer has quoted in his presentation. Essentially, it looked at 178 patients and they randomized them, the polytrauma ones versus the single isolated traumas. They took the polytrauma ones and studied them, and they found that there was a 50% increase in hospital length of stay and 50% increase in morbidity with chest infections if you operated on these patients after 24 hours, but before day 5. And beyond day 5, once you operated on them, all these factors significantly improved. So I think you're right, Amer. We would all go with day 5. Vast majority have said lactate below 2.5, which is appropriate as well, but the timing is what we're trying to focus on, the second hit, preventing that second hit. Okay, great. One final question we're going to share with our audience here is the last case, and we've got one question for you there. So this is a mass casualty which occurs where you've had a bus which has fallen off a bridge barrier and you've got 4 dead at scene and 18 severely injured patients and 14 walking wounded. So they're all coming into your hospital, which is the major trauma center. The severely injured, 18 are being brought to your hospital. Your mass casualty plan has been activated and you're the lead orthopedic surgeon there, taking over and basically running the ops room. Now you've got to organize yourself in the emergency room, and you've got 10 patients with femoral fractures and 8 patients with tibial fractures. Out of those 18 severely injured ones, 10 have femoral fractures and 8 tibial. You've got 4 theaters or ORs available. What are you going to do? Now, once you get to the OR, you find you've got 4 femoral nailing sets and 4 tibial nailing sets and 10 X-fix sets. Who will get the nails and who will get the X-fixes? Okay, so how are you going to decide this? We're pushing that poll to you. Your options are assess their physiology, and if lactate is below 2, then nail, otherwise X-fix. Option number 2, everyone gets a nail. Option number 3, everyone will have an X-fix. Option number 4, perform a triage and highest priority gets a nail. Or the last option, perform a triage and highest priority get an X-fix. So this is a tricky one, Amer. You've got 18 patients who are severely wounded, and you've got a limited number of nailing sets and X-fix sets. And this is what happens in the real world. This has happened to us as well previously, right?
Absolutely.
So it's a tricky time to be involved in a mass casualty event. So how would you go about approaching this with your experience?
I think we've got a large number of patients and we've got a limited amount of equipment. So because it's a bus crash, I probably one of the first things I would be doing while I was waiting for the patients to arrive would be to actually ring other hospitals and try to get them to send equipment, because we're clearly going to run out of equipment. And certainly in the UK there are storage facilities which have got emergency equipment that can be mobilized to hospitals which are pre-sterilized, so they're completely sterilized packs. Now, we've got a lot of patients who need to have surgery, and I think I would definitely want to triage the patients to decide who's going to be treated first. So I'll use the ABCD approach to look at each individual patient, and then I will sort the patients into perhaps an order of who is the most severely injured and needs to be treated first. But for these long bone fractures, if I do a femoral nailing, I know that in my hands, it's going to take me, probably 90 minutes to 2 hours. Whereas if I put on an X-fix, it's going to take me a lot less time. And I've got a lot of patients to get through. I want to have as many surgeons operating as possible. So I'd have 4 surgeons working in 4 operating rooms, but I'd want them all to use external fixation so that we can get through all the patients really quickly, so we can stabilize them all. And that will then just buy us some time. We can then, once we've stabilized everyone, then we can go back and reassess them and stagger the eventual definitive treatment. And if there are patients who are compromised and worried about their physiology, then maybe they've got to wait for more than 5 days until they are suitable to have nailing. And the ones who are not compromised, perhaps with an isolated injury and their physiology is okay, then they can be converted to intramedullary nailing as soon as possible. So that perhaps that answer isn't actually one of those there, but I would actually go for an X-fix for everybody in the first instance.
Mm-hmm. So that's a really well thought out strategy. Whilst we're finishing off, just a quick question to you, and please use the chat option to ask any questions you might have whilst I pose this question to Amer. Amer, with regards to triage, is there a difference in civilian triage, mass casualty triage? Could you just explain? A triage would be to treat the sickest person as quickly as possible, but there is a slight difference to the way we triage in mass casualty events or in the military, right?
Yeah. So when we triage people, we're sorting them into different groups as to how urgently they need to have treatment. So, and it depends on whether we're going to overrun the hospital's facilities. So if the type of the patient or the number of the patients are going to overrun the hospital, then we need to sort the patients into a particular order. So a P1 patient is a patient who has who's compromised and they need to have surgery pretty much straight away. And then there will be the P3 patients who are the patients who were walking wounded, and then everybody in between who might have who can't walk but they're not life-threatening. That they would be P2, but they need to have early surgery as well. So that's the normal way that we would triage people. But if we get to a situation where we're completely overrun, then there's a 4th category, the P4 category, which are patients who are severely ill, but the amount of time and resources that are going to be spent to try to keep that patient alive is going to result in other patients possibly suffering. So it might mean that they're going to take so long, or they're so compromised that we can't possibly save them. And in that case, we would actually put them on hold, and we go for the patients who we could save. So you try and save as many people, so the greater good for the greater number. Unfortunately, we've got to make those decisions that some patients we're not going to expend the time or the resources, because it would result in overall less survivors.
Okay. Thank you. Amer, that was a fantastic talk you've given us, and a great way to sort of pin our colors to the mast when it comes to damage control orthopedics, the evolution of early appropriate care and early total care. We've pushed a handout out to you. It's an article which sort of highlights all the key concepts. So please download that from the section in the handout section, which is coming up on your screen. And whilst we finish off, that's the end of our trauma series for now. We're moving on from next week to a foot and ankle theme. And please do register for this. We're going to be putting the link up on the chat option there for you. For those of you who haven't registered, please do. We're going to be discussing tailor defects, and following that, moving on with some Lisfranc fractures, calcaneal fractures, and then looking at mobile flat feet. I hope you've enjoyed that session. Please do feel free to post any questions you have whilst we wait. And any closing thoughts, Amer, whilst we wait for any questions coming up?
No, but thanks very much for it's been a really sort of interesting discussion that we've had today, and I'm looking forward to hearing you educating me about tailor defects next week, because this is again sort of a controversial area, Raheel's over the years, he's been educating me and trying to drag me into the 21st century, so I'm sure we'll be doing more of the same next week.
Okay. Thank you very much, everyone. I don't think there are any questions right now. So hope you enjoyed that session. We look forward to seeing you next week. Goodbye. Thanks, Amer.
Bye-bye.